So today we are going to start a new topic for final year students, advanced diagnostic aids. Okay, so we have seen clinical diagnosis or diagnosis. Basically, periodontal diagnosis or diagnosis of periodontitis is based on few clinical features. See, to reach to a particular diagnosis, you should know clinical signs or symptoms of that particular disease, right? So, to find out clinical signs and symptoms, we need to have some aids or we need to have some supporting material to identify. So, today we are going to deal with the same part, that is advanced diagnostic instruments or advanced diagnostic aids. Okay. So, any one of you can tell me um, on the basis of exactly what we diagnose a case as a periodontitis, on the basis of which clinical features we record or we come to a conclusion that this case is of periodontitis. Any one of you? Hello, Pallavi.
Gingival status, then bone loss.
Yes, very good. So gingival status, for that purpose what you observe in gingival status? Color, contour, right? You have seen the pro forma of case history. Okay, so but one thing keep in your mind that gingival status, when we discuss about gingival status or features related with gingival disease will give you idea about gingival disease. Okay, so next part of your case history which we have discussed before is of related with periodontal status also. So periodontal status, for what are the factors which are there in periodontal status? Name some, enumerate some. What what are the periodontal status? Which factors decide periodontal status? Hello, you got my question? So in your periodontal status, there are 4 different categories. So either you have to see periodontal pocket related with that particular tooth, or there should be loss of attachment, that clinical attachment loss for periodontal pocket. For both the things, you need to have some periodontal probe, means instrument which are there are periodontal probe to identify this. Other than that, what are different status? Periodontal status in that, first is probing pocket depth, second one is clinical attachment loss, third one is what? Mobility, fourth one is what? Pathologic tooth
Furcation
evaluation.
involvement.
Yes, furcation involvement. So all these things, to detect all these things, we need to have some instruments, right? So we are going to discuss about the manual and whatever the instruments, advancement in these instruments. Which instrument we use? Any one of you? Which instrument we use to detect all these things? We use periodontal probe, right?
Probe.
Yes, probe. For furcation, we use some different, like neighbor's probe we use for
Neighbors
furcation.
probe.
Yes, okay. So we will see the conventional routine diagnostic. For diagnosis, actually, we record clinical case history or dental medical case history, then signs of periodontal inflammation. They are mainly probing depth, clinical attachment loss, recession. All these things we record with the help of manual probes. Other than that, for diagnosis, somebody said me that bone loss is also one of the feature to detect periodontitis. Okay, so to detect bone loss, whether it is possible to see orally in oral cavity clinically with your eyes, will you able to see bone loss? For that purpose, you need to have radiograph. Okay, so radiograph, you can have IOPA, you can have OPG or bite wing type of radiographs or any other type of radiographs advancement in that. Other than that, the causative factor for periodontitis is mainly of microorganisms which are present in the oral cavity. So in microorganisms, main microorganisms which are there are periodontal pathogens. You know, 4 different pathogens. Okay. So, but detection of these periodontal pathogen, exactly you should know which periodontal organism or which periodontal pathogen is causing disease. For that purpose, you need to have some different types of microbiological test. Okay. So to detect whether the causative factor means the patient who is having periodontitis, you need to collect some amount of plaque from that patient, some amount of saliva to diagnose or to detect the periodontal pathogens which are associated with that particular patient. Okay, so detect that also microbiologic different microbiological tests are also required. So we are going to discuss advancement in that microbiological test also. Other than that, histopathological, then other different types of diagnostic tests like routine hematologic tests. Other than hematologic tests, some biochemical tests are also there, and other than that, some genetic tests are also there. That advanced diagnostic aids is comprised of 4 different types, 4 different tests. First is related with clinical diagnosis, that is with the help of probe. Advancement in that we are going to discuss. Second part of this advanced diagnostic aids is diagnosis related with radiographs, advancement in radiographs techniques. Third is related with microbiological and biochemical tests. And lastly, we are going to discuss about the genetic tests, various genetic tests. I think in your 12th, you people have gone through various genetic tests, like various genetic diagnostic tests which are there, like agarose gel electrophoresis. Other than that, hybridization. So all these are slightly molecular level genetic tests are there. So we are going to discuss all these things. First, today we will discuss about your first clinical tests or clinical diagnosis. So clinically, diagnosis of periodontitis is mainly based on use of a ad hoc instrument, that is periodontal probe. Periodontal probe is inserted in the pocket, and periodontal probe we insert in periodontal pocket area in 6 different areas around the tooth, and we discuss it or we write it particularly associated. In your case history pro forma, there are 4 different parts of a single tooth. You have made 4 columns, right? In column 4 categories are there, that is mesial, distal, then buccal and lingual. So you write periodontal probing depth related with that. So manual, any one of you can tell me which are the manual probes which we know use for in your OPD area. Which periodontal probes we use? Any one of you? So manual probes, any one of you can tell me manual probes? Various manual probes are there. WHO probe is there, right? Other than that, huh? Any one of you? Williams probe, we use Williams probe also. We use Williams probe, we use, huh?
CPITN.
Yes, very good. CPITN or WHO probe. Other than that, Michigan O probe is there. Other probes are also there. Means Michigan O probe with WHO markings are there. Marquis color coded probe is there. Goldman Fox probe is there. So these probing systems which are there, they are made up. They are advancement lead to formation of generation in periodontal probes. So manual or handheld probe which we use in our clinic, we call it as a first generation probe. Okay, so first generation probe are mainly handheld probe or manual probe. Okay, so manual probe we use with the help of hand. So these manual probes are of different markings are there. All of you know markings. You people in third year, you people have seen that Williams markings are there. 1, 2, 3, 4. 4 is there. 4
No,
is
ma'am.
missing. Yes, 4 and 6 is missing. Rest all are 1 millimeter markings are there. Okay. So first generation probes are conventional probes or handheld or manual probe which we use in our clinic. Okay. So this probe exactly. Can you tell me method how to insert a probe? Any one of you can you tell me how do you check pocket? Gajanan, how do we use probe?
Insert
Maheshwari?
the probe longitudinal to the axis of tooth.
Yes, very good. Parallel to the long axis of tooth, not longitudinal. Okay. So parallel to the long axis of the tooth, we insert probe in sulcus. Right. So while inserting, how much should be the probing force?
25 grams.
Yes, very good. Very good. 25 grams. So, how do you measure 25 grams? Who is answering?
Rajni.
Rajni. Okay, Rajni, are you able to decide how much is probing force? 25 grams.
Ma'am, it is the force we actually decide by probing our nail, but means that much force should be there.
Yes, that much probing force should be there. But how you will able to decide that 25 grams while inserting? Suppose a patient is there and you are inserting your probe in sulcus or in pocket. So, will you able to decide that you are inserting accurately 25 grams? Is it possible?
It resists the probe.
What
The
resists the
sulcus,
probe?
the sulcus depth.
Okay, the base of the sulcus, if it is comprised of a healthy tissue, that healthy tissue will resist the penetration of probe, right? But I am asking, while inserting, you will able to measure the probing force? No, there is a test. Nail bed test is there. Nail bed test means what? If your thumbnail is there, you have to insert the probe at the base of your nail bed, and you will able to. When you feel irritation, that much amount of probing force you have to insert in your sulcus. But is it possible to insert the in the same area? See, for periodontitis, a patient is suffering from periodontitis. You have measured in his first visit probing depth. Okay. So probing depth which you have marked in mesial area is 7 mm. Again, next time patient, you have treated your patient and patient is coming back to you after 1 month. Again, you need to review the patient. You need to reinsert your probing force, right? Probing, you need to insert your probe. Then only you will come to know that whether your treatment has worked or not. Are you getting my point?
Yes, ma'am.
Huh. So, for periodontal patient, you need to do continuously, frequently at every visit. Probing, you need to do frequently. So, is it possible to insert your periodontal probe with the same amount of probing force in the same area, with the same angle, whether it is reproducible? Is it possible? See, it is not possible. It is very difficult to insert your probe in the same patient, in the same area, in the same visit. Means if you are inserted at mesial some mesial line angle or mesiobuccal line angle at one visit, and next time you may insert in the proximal area directly in the contact point or close to contact point, but you may forgot that in which area you have inserted your probe, the direction of probe, site of area, or where exactly you have measured. All these things are very difficult to do with manual probing. So for that purpose, advancement means probing force, maintenance of probing force is also difficult in the patient, those who are having inflammation. If tissue is healthy, it will resist the probe to penetrate inside the underlying tissue. But if the tissue is inflamed one, so that tissue will allow the probe to go in the sulcus beyond its base of the sulcus, means inside the connective tissue directly. You may insert inside the connective tissue, and that is the reason why bleeding occurs. Okay, got it? You when you insert probe, bleeding occurs most of the times in inflamed area. What is the reason of bleeding? Because you have reached beyond the base of the sulcus inside the tissue, inside the connective tissue. You have reached inside the connective tissue and you have hurted some blood vessel in that area, and that is the reason bleeding occurs. Okay, so it is very difficult to maintain the probing force in subsequent visit, in the first visit, in the second visit of patient, and in the third visit of patient. It is very difficult to maintain the same amount of probing force. So to avoid this, next generation probe, it came in the market, that we call it as a pressure sensitive probe. Pressure sensitive probe are nothing but they are associated with a coil, or one spring is there. See, I'm sharing one slide where advantages of this manual probes are there, or first generation probes. Are you able to see this?
Yes, ma'am.
So advantages of manual probe and disadvantages of manual probe. Disadvantages are related with errors during visualizing the reading, and assistant is needed to transfer to chart, because while recording case history, you people record two students record for a one single case history, but it is very difficult to locate the pocket and the same time writing in your chart. So one assistant is needed. Then while inserting the probe, angulation, all these things, it is very difficult to insert in the same angulation. For that purpose, you need to have some stent on which a groove is created, and in the same stent is inserted on the tooth. And you people, if you have book with you, you can just go through the book, Advanced Diagnostic Aid. How many of you have perio book with you? Hello, Pallavi.
Yes, ma'am.
How many of you people have your perio book with you at home? Okay,
Almost all, ma'am.
you people have perio book with you right now.
No, ma'am.
Okay, let it be when you will join back the college. That time you just go through the book again, and if you have any problem related with this first generation probe, we'll discuss it again in your clinical questions. Okay, so
Yes.
just keep this thing in mind, that the problems associated with manual probe is diameter of probe varies from one probe to another probe. Other than that, markings are also vary from one probe to another probe. Means one probe is Williams markings are there, other one is having WHO probe is there. Other than that, there is no standard related with manual probe. So because of that, and even probing force, you will not able to decide. You will not able to, if calculus is there, you will not able to detect the CJ with the help of this probe. So these are the disadvantages related with manual probe, and for because of that, pressure sensitive probes they came in the market. The pressure sensitive or true pressure sensitive probe, it is mainly made up of a, see here, are you able to see this probe, true pressure sensitive probe, image of this probe? So this image of this probe, this handpiece of probe is made, inside this handpiece there is a spring coil. This spring coil maintains probing force up to 30 grams or 50 grams, and beyond that it will not increase your probe, 50 grams for osseous detection, osseous defects, and 30 grams for reaching to the base of the sulcus. So standardization is there, but the main disadvantage with this is you are losing your tactile perception. It is advantages are mainly comfortable to patient, and there is standardization of probing force and constant pressure is there. For every area there is constant probing force is there, but again some areas patient having means generalized pockets is different one, generalized inflammation is different one, but some areas are healthy, some areas are inflamed one, so you will not able to maintain the same amount of probing force, because in the healthy area if 30 grams of force is there, it will reach to the base of the sulcus. But in the same probing force, if you apply to the inflamed area, it will reach beyond the base of the sulcus inside the connective tissue and hurt to the tissue. So these are the disadvantages of constant pressure. Okay. Other than that, probe tip may the same disadvantage just now I have discussed. Then and another assistant is required and computer storage is not there related with this probing system. Okay. So again, next generation probe came in market. These are the computer sensitive probes, third generation probes. So computer sensitive probes, there is controlled force, automated measurement and computerized data storage. All of you have seen RVG, which is there in endo department, radio videography. You people
Yes.
you people might have seen the software of that. There are different tooth images are given in that software. So the area where you want to click the radiograph, you need to click on that particular tooth, and you will able to take radiograph of that. The similar manner, third generation probe is a system made up of software. In that software you will able to see, you will able to, if you want to measure the pockets related with upper six, upper right six, you need to click on that tooth image, and you have to insert inside the patient's mouth. This computerized system is having, see here I'll show the image of this Florida probe system. This is digital interface where you will able to see, then a foot control is there, long coil is there. Other than that, this is the probe. Here probe tip is there. This probe tip comes out through a sleeve. Here a sleeve is there. From that sleeve, the probe tip come out. There is standard diameter of this probe is maintained and computerized storage of data of first visit and second visit of patient or third visit, means all visit data will be maintained properly in this system. So this third generation probing system is very good type of probing system where pressure is also maintained, data storage is also there, standardization of diameter, all the things are standardized. Here you can detect CJ also. So Foster Miller probe or some probing systems are there where another small thread is there with which you can measure CJ or you can locate CJ also. CJ is required to locate, CJ is located to measure clinical attachment loss. Clinical attachment loss is very important findings for periodontal point of view. Okay, so these are the different probing system like Florida probing system, Foster Miller probe is there, then Toronto automated probe is there. So this automated probe system is consists of handpiece digital readout, foot switch, then a computer interface and computer. The only thing with this is very costly type of system, and the same because the same amount of probing force is not able to apply in all areas of oral cavity, because some areas may be more inflamed than that of previous one. So few areas will be inflamed more, few areas might be inflamed lesser in lesser amount, but the same amount of probing force if you are using for all areas, it will hurt in inflamed area. So, okay, so standardization of that probing force also may be a drawback. Other than that, disadvantage of this probing system is loss of tactile perception. Tactile perception means what? You will able to insert with your tactile perception. You will feel resistance sometimes. That resistance may not be felt with these systems. Okay. So these are the different system, that is Florida automated probe. Other than that, Mueller probe, then Toronto automated probe. Okay, so based on the university, it is named Toronto. So disadvantages: it lacked tactile sensitivity, mainly because of independent movement of movement. Use of fixed force, the same which I have told you just now, inaccurate measurement, and may lead to patient discomfort. Then fourth generation probe and fifth generation probes, they are not fully developed. They are under development. They are, because of that, they are not in the market. Only the problem in this fifth generation probe. This fifth generation probe is also again based on ultrasonographic probes. Means what? The movement of the fluid inside our soft tissue will guide you, or the probing system is guided by that fluid movement. But these are not fully developed, so because of that, they are not able to use in the market. Okay, so up to third generation probes are or probing devices are developed properly. So you people may get long note on this question, that is advanced diagnostic rate, or sometimes you may get soft various short notes on Toronto automated probe, Florida probe, or other radiographic advancement like CADIA or subtraction radiography. Okay, so we'll go further. This is temperature sensitive probe. It is considered that inflammation may induce the thermal changes in the tissue. Okay. So if tissue is inflamed one, it will induce thermal changes. So thermal changes can be measured with the help of temperature sensitive probe, which is devised by Abiodent company. So this temperature sensitive probe will give you idea. There is different color codings are there here: red, orange, and green. So temperature, where temperature is normal, there you will see findings of green color, and other than that, you will see the color like orange or red. Okay, we'll discuss advances in radiographic assessment. Usually we record IOPS, but for IOPS there should be some amount of loss of bone. Almost 30% bone loss should be there. Then only it will be visualized in the your IOP. So that is the main drawback related with IOPA. Sorry. See, will continue this lecture in the next half. Microbiological advances, radiographic and immunologic advances. Okay.